So good morning, everyone. This is the fourth talk of the first session and devoted to TB prevention amongst previously treated people. I'm going to focus explicitly on settings with a high incidence where we believe these data and thoughts are especially relevant. Just to sort out how this works. Yeah, so what am I going to do as part of this talk? I'm going to start off with a concept of the natural history of tuberculosis after treatment, and then I will provide a snapshot of what we know in terms of the data, the observational data about tuberculosis after treatment. I will link the evidence from observational studies then to some modeling work that we've done around targeting prevention to previously treated people, and open up the conclusions for you to discuss if you think that's relevant. This is a slide by Gerhard Walzer and his group, published in 2011, where he outlined very nicely the natural history of tuberculosis after treatment. In this concept, we see there is so he distinguished three different phases. One is the sterilizing cure after treatment on the left side in the middle. He then distinguished clinical cure, described as a quiescent phase of bacteria, where treatment leads to basically the immune system controlling tuberculosis but not getting rid of the bacteria, and down to the right-hand side, where treatment leads to treatment failure, the failure to treat patients and get rid of tuberculosis. And one could also think of this as a continuum between patients on the left-hand side, maybe a small number of, or a small proportion of patients where we are certain we get rid of tuberculosis through treatment. They're sterilized. This type of tuberculosis, if not reinfected, will lead to long-lasting cure. To possibly a large fraction of patients that we enable through treatment to control tuberculosis through their own immune system, and those you can see they can either they can relapse and develop recurrent tuberculosis, and they can also become reinfected. And down to people who obviously are still sick, so they have persistent tuberculosis despite treatment. So we see we have either the outcome of lasting cure, we have the also lasting cure by controlling infection, and we also have people who develop recurrent tuberculosis. What is the evidence from data? So this is a slide of the evidence in Southern Africa between 1993 and 2013. We see on the X scale the rate of recurrent tuberculosis in HIV uninfected individuals per 100,000 person years in different studies, and on the Y scale the same for HIV positive people, and we can see that the rates of recurrent tuberculosis after successful completion of treatment are quite significant, starting from about 0.5 per 100 person years up to 7 or 8 per 100 person years in HIV negative people, and up to 25 per 100 person years in HIV positive people. So very high rates of recurrent tuberculosis amongst people who we actually have sent home saying you've completed your treatment, you're fine, you probably will not get TB again. How much of this recurrent tuberculosis after what we think was cure is due to reinfection? There are several studies that have looked at this, and we believe that the proportion of, or the fraction of recurrent TB cases that is due to reinfection events, this is shown on the Y scale, is proportional to the incidence of tuberculosis, the background incidence, which makes a lot of sense. The higher the force of infection in a particular setting, the higher the probability that people become reinfected. Here I show data from a study that we've submitted recently. This goes out from the notification data. So this is the electronic TB register in South Africa that we've used, and we conducted an ecological study at the level of the 52 South African health districts. And the figure, the map shows the percentage of tuberculosis cases notified that are previously treated, classified as previously treated, and we see a huge variation of this proportion, up to 40% in some of the districts in South Africa of patients are previously treated, and then also it's not very well to see, but in the bars you can see that the majority of these previously treated people actually report a history of successful prior treatment. So this shows us that previously or recurrent or previously treated people contribute substantially to the diagnosed burden of tuberculosis. Just briefly to mention that we also have data from the ZAMSTAR study here from the ZAMSTAR prevalence surveys published, where we have looked at the proportion or the fraction of people in the survey populations that report a history of tuberculosis. We can see here on the right-hand side, this is specifically the communities in the Western Cape province with a very high prevalence of tuberculosis identified in these surveys, and between 10 and 15% of the survey population reported a history of tuberculosis. So 1 in 7 or 1 in 8 of the adults, regardless of current tuberculosis, were previously treated. And then you can see that the estimates of prevalent tuberculosis are quite high, between 3 and 7% prevalent, undiagnosed or undetected prevalent tuberculosis amongst people reporting prior treatment. And what you can't see here, but if you look at the fraction of prevalent, undetected prevalent cases that have a history or that are in households of people who have been previously treated, then up to 30–40% of those cases are from those households with treatment history. Yeah. What do we know about preventing recurrent tuberculosis? So this is a systematic review that has been done on preventing recurrent tuberculosis amongst HIV-positive people. And we have 3 randomized controlled trials and 1 cohort study, and they all show that you can, by doing post-treatment isoniazid preventive therapy, you can actually prevent up to 80% of recurrences amongst HIV-positive people after treatment. So just to summarize, what do we know? We know that there are high rates of tuberculosis after programmatic successful tuberculosis treatment, and these high rates are exacerbated by the probability or by reinfection events in the population, especially in high incidence settings. We know that previously treated people contribute substantially to incident and prevalent tuberculosis in these settings, and we know that preventive therapy is effective to actually reduce recurrent tuberculosis after treatment. What we don't know, the unknowns, we really don't have enough knowledge still about what really determines these high rates of recurrence. So one question is this just a selection process? Do we have heterogeneity in the population, and do we see or do we observe a selection process of people who were much more likely to develop tuberculosis at the first incident? So if you illustrate that, how high will the annual risk of infection be in these settings? Probably between 4 and 5%. That means by the age of 18, about 80% of the people have already been infected with tuberculosis. And it's quite surprising then only 10 to 15% of people report that they already have been treated for TB, which tells me either a lot of people are not found, but develop active tuberculosis and survive, or we have substantial heterogeneity in the large fraction of the infected people actually containing infection, and then we might actually see people who already have proven at the last incident that they had active tuberculosis after infection, that they developed tuberculosis again. So we think this could be a selection process of people who are either more likely to become exposed and infected, or who are more likely to progress for whatever reason. Maybe it's related to the quality of treatment under routine program conditions, and maybe also the role of inflammation and lung destruction is important to consider, especially in areas where patients take a long time, or individuals take a long time until they are being diagnosed, or they seek care and are being diagnosed. We know very little at the moment about the extent and duration of infectiousness, and also we don't know to what extent previously treated people contribute to the acquisition and transmission of drug resistance in these settings. So we've taken this to the next level, and we thought, okay, we have a lot of data, and we've developed a mathematical model of prevention and case finding targeted to people who completed tuberculosis treatment. The model is shown here. It distinguishes the treatment-naive people who have never been treated. Then in the middle you see two treatment compartments. We assume here that treatment is either remains incomplete or treatment is completed. And then amongst people who complete treatment, we have two interventions. One is we allocate them to an intervention arm of secondary isoniazid preventive therapy, and we also have a second intervention which shows which is active case finding. So we assume that we can actually annually find tuberculosis in this subpopulation. This makes especially sense to combine these interventions because you want to rule out active tuberculosis before you actually put people, or before you put people on preventive therapy. We calibrated this model to data that we had from a high burden setting in suburban Cape Town. So here we have, like in the first few panels, we have case notification data, we had population data, we have an estimate of HIV prevalence in these two communities, and we have prevalence survey data, including prevalence of tuberculosis by treatment history. So one of the central aspects of this model is that we did not force the model per se to have high recurrence rates, because that affects our the impact of our interventions, but we let the Bayesian calibration approach decide how high these rates are based on observed data. What we found in our model, those are the projections over a 10-year period, incidence, prevalence, and mortality. We can see that targeted active case finding alone led to a reduction of about 14% of incident TB cases over a 10-year period, 21% of deaths. And if you combine case finding with post-treatment preventive therapy, then about 40% of incident TB cases and 40% of deaths could be averted in that setting, including among people who never have been treated, including children and other people. So if you think about the discussions that we had yesterday about, okay, what can we achieve through interventions per year in terms of reducing incidence, we said that anything that's beyond 10% is unrealistic, but the combined intervention here corresponds to about 4.6% of a reduction in incidence per year, which I think would be a very attractive way forward to achieve that if it was possible. So this is very briefly just to say that we are continuing this work. We are doing a cost-effectiveness analysis at the moment where we look at more specific interventions here, post-treatment follow-ups. So the idea here is to have, this is a 2x2 intervention design, factorial design, where we say we can either follow up people once after 12 months, or we can do this once per year for lifetime. This is the lower left. And then we can combine these follow-up examinations after treatment also with preventive therapy, either for 12 months or longer than 12 months. And we're currently looking at the cost effectiveness of these interventions. So those are very preliminary data, but it seems from what we see that using prevention is actually cost effective for tuberculosis control in these areas. So there are a lot of questions around, can you do it? But I think just from the modeling, we have a lot of evidence to actually pursue this idea and actually make it happen, hopefully as part of a trial maybe. In conclusion, I think we've seen that in high incidence settings, preventing tuberculosis amongst previously treated people may be an attractive strategy to achieve better impact, to reduce tuberculosis, especially in high incidence settings. And you can see that we've started off from data, and data have informed models. So this is an example of a targeted intervention of prevention, which I think we need to consider given the heterogeneity of risk in these communities of people who are much more at risk of being exposed, being infected, and maybe also much more at risk of progressing to active tuberculosis. I want to acknowledge my colleagues, especially my thank goes to Ted Cohen and Reza Yezoubi from Yale University. So we've been working together with Nick Menzies and Josh Salomon and Alyssa Belinsky from the Harvard School of Public Health, Nolda Bayes, Anneke Hesseling from Stellenbosch University, and Edina Sinanovic, University of Cape Town. I also acknowledge my funders, and I thank you very much, and I think we have a little bit of time, hopefully, for 1 or 2 questions. Thank you.
Yes, indeed, we have a few minutes for questions. Frank?
So, thanks, Florian. In your model and in the cost-effectiveness work that you showed, what is your assumption with regard to the potentially increased risk of reinfection following disease? Because that has been sort of in the middle, I think. That's...
Yeah, there's a big risk in these models to actually model or to put in the model structure or in the model assumptions what you actually want to find as part of the outcome. So the higher we assume recurrence is in this model, the higher the impact will be of these interventions. So we've really try to be conservative about the parameters that we've used. So what we've done is we've used the same disease progression risk after reinfection, after tuberculosis, than amongst people who are just latently infected and may become reinfected. But we allowed the model to sample from the same prior ranges here. So we have not assumed per se higher rates of reinfection after treatment.
Thank you.
What?
Hey, thanks, Florian. That was great.
Thank you.
My question is, have you thought about modeling 3HP in this in terms of either the effectiveness or the upcoming cost effectiveness? And then there was data presented at CROI that even 1 month of some preventive therapy would be helpful as well. Do you think that modeling those 2 aspects or some shorter regimen would make your case even more compelling?
Yes, that's a really interesting question, especially with the new regimens that are upcoming for preventive therapy. If you compare preventive therapy amongst HIV-infected people, where we've been quite disappointed because we see we need to actually continue with preventive therapy lifelong, and as soon as people stop, people are back at their very high risk. Here we have an interesting situation because the highest risk of recurrence is really happening in the first year or the first 2 years because of the additional risk of relapse. So one could really think about even going shorter than 1 year and saying, okay, maybe we need to find people at month 3. Maybe we need to prevent at the height of relapse, which is about 6 to 8 months. And I think that's so the answer is yes. What I don't know from the new regimens is what happens once you stop these therapies. Are you going back to your risk? And those are things one should really explore in trials at some point. Yeah, thank you.
Thanks, Florian. It seems to me like, just from a practical point of view, a major advantage of a strategy like this is you have the addresses of these people because they've been previously treated. How much of a driver of the cost effectiveness is that?
Yeah, so it's interesting because we have, those are not people who never access healthcare, right? So those are people who we already had, and we treated them already. So there are 2 ways you can use that. You can either use records in treatment centers to follow people up, or you can actually agree right at the end of treatment that you invite people back to come. So those are ways. I think these people might be especially accessible to additional interventions because we already had them at our centers. We have done a pilot study now in Cape Town where we looked at people treated in the past 5 years, and we tried starting from treatment register information to go to their households. And surprisingly, we found a very high mortality. That's the first thing. A lot of people actually die. And it's also not as easy as we thought to actually find people in the households because people, especially when people move a lot. So we think that either making an agreement with people right after treatment or using a screening strategy where you go to household but you stratify your case finding and prevention according to what people tell you as part of household surveys. It might be difficult to actually use register data, but certainly that's one of the things we also thought about. Yeah.
And would you look for other types of post-tuberculosis lung disease or just new TB?
Yeah, so we did this as part of the study. So we've looked at pulmonary symptoms. We've screened for tuberculosis. We found 2 people after treatment who were still on treatment, again on treatment. We found 1 person who was culture positive and expert positive without being currently on treatment. And we found a lot of people who reported that they have difficulties breathing, they have difficulties to walk up the hill, they cannot, this is consistent with what we believe, that there's actually a big burden of lung disease, which also relates quite nicely to what Paul has shown this morning. We assume that many people at the beginning are asymptomatic, but we know that a lot of people are actually already quite sick and they have lung disease, they're smoking, many of them are coughing, there's high rates of chronic lung disease other than tuberculosis. And how does that affect infectiousness of people and transmission? We don't know that. Yeah.
Frank and Daniel.
I'm sort of puzzled because if you don't, and I think for good reasons, but if you don't make the assumption that there's an increased risk of reinfection disease following treatment, then it's all about relapse, isn't it? Or it's mainly about relapse, at least in the first period. If it is about relapse, why do a lot of interventions in relapse? We know only a very small proportion of relapses. That's one, true relapse. We know it relates to the duration of treatment. There have people actually argued that you should simply extend treatment. The question is, for whom should you do it? Actually, we know from the old trials that probably only 30% of patients with current regimens need treatment beyond 2 months. So it's a very small group that is somehow different. So then my question is, and that's a bit of a devil's advocate question, why go all the way for this very small group in this way? Why not go the biomarker way and try to find out, can you actually predict them? Because otherwise you're going to throw a lot of effort and a lot of money at a big group in order to prevent a few cases.
Yes, thanks Frank.
It's a small
excellent comment. To your first question, we allow for a higher rate of reinfection. So what we don't distinguish is exposure. We don't have differential parameters for exposure here. We allow for people to be more likely to progress after reinfection. But we don't define this per se. We have different prior parameter ranges, but I think the model in the end shows that there, according to the calibration data, that there is a higher rate of progression also in these people, plus relapse. So I think I think the truth is it's both relapse and reinfection, and we need to better understand how long, because it has implications on the temporal dynamics, how long to design our interventions post-treatment. To your second question, the answer is clearly yes. If we have 10 to 15% of the adult population in these settings with a history of tuberculosis, that is still quite a big group to actually target. Why not really doing a study before even doing interventions and see if we can narrow down this group to people at the end of treatment who might be at even higher risk for so far unknown risk factors, people who have residual cavities, who we know have a higher risk of recurrence, people who are HIV positive, people who or have other risk factors that we know for tuberculosis at the end of treatment, and narrow down our intervention maybe to a group where we are even more certain they're going to come back with tuberculosis. So this is, I hope we're going to get funding for that, because I think it needs to be done. Yeah.
So just to comment on,
Well, first Daniel, and then we'll come back.
okay.
Yeah, so you mentioned that as one of the major risk factors for recurrence is treatment quality. And now there's really growing evidence that of the relationship between adherence and relapse. Did you actually look at, as part of your model, compared to what you mentioned, which I think is actually quite convincing, that of the value of post-treatment follow-up. But I think that one thing that you could add to that, maybe you've already looked at it, is what if you improve adherence? In other words, you prevent these recurrences in the first place, and compare the cost effectiveness of that compared to doing this, because somebody's going to ask that question, right? Why don't we prevent these recurrences in the first place compared to following them up and then giving them treatment?
Yeah, I would really like to discuss this further. This is an excellent idea, because we could include measures of not what we define as treatment default or loss to follow-up, but as compliance during treatment. So how often do these people actually really take their drugs, and how does that affect the risk of coming back with tuberculosis? And really like trying to identify clinical and maybe immunological markers of the people who actually need follow-up or even longer treatment. That's definitely a question. I don't think that in these settings it's all about the quality of treatment, because we have a lot of evidence of reinfection tuberculosis. I think Susan Verver, we've repeated that with the temporal dynamics. I think we have consistent data now that reinfection matters more than we thought previously. Yeah.
So just to piggyback on Frank's comment, I think establishing a dedicated team to just look at this particular problem may be very, very costly, and I think that's Frank's point. But like in a way that these are a lot of combined factors: reinfection or getting the disease back because of the. So I mean, look, I think it's these kind of findings are very important, because then these are strategies that, where a very established team of active case finding or addressing TB problems in the community can look at and profile these patients accordingly to these. So diversifying portfolio for these community healthcare workers or teams to look at these kind of problems, more catered approach, so that the initial investment of establishing these kind of investigative teams to address various types of things accordingly, so spread out the cost along, that may have impact, reduce the potential burden of the financial burden of looking at these. Like this is one of the kind of part of the investigative things.
Back then.
I have two issues. One is that the South Africa situation is a very, very, very high incidence situation, which is specific. So the question is, how generalizable is what we find in South Africa to other settings? And I have to ask it because I'm representing the European Union, which is a much lower incidence area. But my actual question is actually, and that has to do with relapse or reinfection, because if you're going to provide preventive treatment to this group after they have basically been cured or at least completed treatment, and then it's a different group than if you provide latent TB infection treatment without them first having had TB. So, and especially if there's a large proportion which relapses, my question is, what kind of drug resistance are we going to create if we provide preventive treatment?
Yeah, that's a very good point. To your first point, the question, is this relevant, or is this relevant also for lower burden settings? First of all, yes, we're talking about high or even highest incidence settings, but we really believe those are the places where we have the most urgent need to do something, because we're not going to achieve, we're currently not achieving disease control in these settings. They're failing with programs in place. Yeah. Whether or not these interventions make sense in lower burden settings, I think one would have to really think carefully about the risk of relapse and reinfection in lower burden settings. We know that in lower burden settings the risk of relapse is quite high as well, even under extensive care. But what I think where these interventions can be especially attractive is high MDR TB settings. So a question that we have very rarely asked is who is actually transmitting multi-drug resistant tuberculosis in Belarus and in Kazakhstan? Are these people who have just recently been infected themselves, or are these people who have been exposed previously? So I believe applying this work to high MDR TB settings will actually show us that you will have even less people with a history of tuberculosis, but this might be really an important strategy to reduce transmission of drug-resistant tuberculosis, because those are the highest risk group, former TB patients, to actually develop drug resistance and to transmit.